goal of this is to focus a little bit more on the what testing should be done for patients who are coming in for non-cardiac surgery. So, all the way to the thing. Sorry, 1 second. So with preoperative assessment, this is something that we all do day in, day out. Obviously, get a medical history, do a physical exam, and then evaluate any of the indicated testing that we have. Labs, EKGs, stress tests, etc. With medical history, this is obviously current and past medications, reactions to previous anesthetics, drug allergies, coagulopathies, any pertinent family history, all things that we focus on. So what are the goals and advantages of doing a very thorough preoperative assessment? Primarily, I think when it comes to doing a outpatient preoperative assessment for these patients who need more thorough investigation before they come for surgery. The goal is always to decrease patient risk and morbidity, increase efficiency in the OR, decrease cancellations, and prepare the surgical team as well as the patient for this procedure. So whenever we discuss evaluating patients, we always talk about urgency and risk, and we'll get into this a little bit more. So when we talk about urgency, we talk about emergent versus elective. Elective cases can be delayed for up to 1 year versus emergent cases have to go within a few hours. Time sensitive is a little bit more where there's gray area. These are cases that need to get done in a timely manner, otherwise there's going to be potential harm for the patient. This is going to be affected with oncological procedures, where we get put in a situation where we have a critical patient who needs to have surgery. How do we optimize them for this? So in order to further evaluate, we talk about low versus high risk. There used to be an intermediate risk category. However, given that the recommendations for intermediate and high risk are the same, they've split it into low versus high risk. Low risk is going to be where the patient's surgical and medical history is going to give them a less than 1% chance of having a major adverse cardiac event. Whereas high-risk procedures, they have a greater than 1% chance of this occurring. Low-risk procedures are going to be cataracts, things without significant fluid shifts, things where you don't need a very thorough workup to go through a very low-risk procedure. So how do we evaluate risk? It comes down to risk indices. Now, previously, we used to use the RCRI risk indices, which is what we've been using for like over a decade now. The RCRI is going to evaluate patients as far as heart disease, any diabetes, kidney disease, cerebrovascular accidents, and it gives us an idea of the risk for an adverse cardiac event for these patients. More recently, they've come out with the American College of Surgery guidelines. Now, this is a very thorough guideline that's come out. It's a marker of 21 predictors of risk. 21 predictors of risk for major cardiac complications. This was something that was done in over 500 hospitals, included over 1 million operations, and it actually outperformed RCRI for evaluating patients. It can indicate major adverse cardiac event, pneumonia, prolonged hospitalization. It's actually been very thorough, and it's what's recommended in the most recent AHA guidelines. So this will kind of give you a better idea of how to compare the two, RCRI versus the American College of Surgery guidelines, and how thorough the American College of Surgery guidelines are. Now, whether this needs to be done for every patient is a different story. I think at this point, that's where clinical judgment comes into play. So when we compare the two as far as how they were done, we talk about methodology versus patient population. As you can see, the American College of Surgery guidelines included over 400,000 patients, whereas the RCRI guidelines